Good morning and welcome back to Journal Club. Today we'll be discussing the issue of STEMI after transcatheter aortic valve implantation. Today's presenter is Dr. Evelina Toscano, and we will be joined by two experts today, Francesco Giannini from Maria Cecilia Hospital and Carlo Tumscitz from the University of Ferrara. I hope you enjoy the discussion and looking forward to your participation.
Good morning, everyone. Welcome to today's meeting. The paper I'm going to present is this one that was recently published in JACC, reporting the outcomes of STEMI patients after TAVI. We are in a field that I think is an hot topic in contemporary TAVI era because we are dealing with coronary access after TAVI. And so my agenda for today's meeting, I give you some slides about the background of coronary access after TAVI, and then the problem of acute coronary syndromes after TAVI. Then we will read together the paper, so the methods, results, and conclusions. And then in order to introduce the discussion, I'll present some tips and tricks for coronary engagement after TAVI, and how to potentially reduce the risk of having trouble when performing PCI after TAVI, and also the concept of Commisure Alignment. And then, as usual, I will finish my presentation with my question for discussants. So let's start. Why coronary access after TAVI? Actually, 40 to 70% of patients receiving TAVI exhibit some degree of coronary artery disease. Of course, this percentage differs among populations in registries and clinical trials, but in general, it's very significant, the presence of coronary artery disease in patients with severe aortic stenosis receiving TAVI. And of course, as indication expands lower risk patients, so we expect them to have a better long-term prognosis, there will be an increasing need for repeat coronary angiography and PCI due to progression of CADE development of acute coronary syndromes. And I think we are in a new field of TAVI in which, compared to first generation implantation, in which the major endpoints were death, stroke, and major bleeding, we are now working with new generation valves, and so new outcomes. We want to put at minimum the risk of death, stroke, major bleeding, major vascular complication, but there are also other endpoints that may also impact on long-term prognosis, like pacemaker implantation, paravalvular regurgitation, and of course the problem of valve durability and coronary access. So what is the problem of coronary access after TAVI? We have a prosthesis in front of our coronary ostia. So there are anatomical and device factors that impact on coronary access. For sure, the anatomy of the aortic root has an impact because the aortic root has its features that may impact on coronary access, in particular the height of coronary ostia, of the sinuses of Valsalva, the width of the sinuses of Valsalva, the dimension of the sinotubular junction, and of course the leaflets, the height and the bulkiness of the leaflets. Moreover, we are dealing with prostheses that are made by extreme simplification of a metallic frame and tissue organized in leaflets, commissures, and skirt. So the commissural tab orientation, their position are important, as well as the presence and the height of the skirt and the implantation of the valve, the depth of implantation of the valve. And the problem of coronary access after TAVI has already been studied in several ways. These are the insights from a study published last year of a CT scan performed after TAVI in patients receiving SAPIEN or Evolut valve. And actually, 22% of patients with Evolut valve had the position of the commissural triangles in front of the coronary ostia. And in 12% of cases, those were below the skirt. These percentages were significantly lower instead with SAPIEN valve. And this was a CT scan study, but we also have data from the coronary angiography performed after TAVI. These are the results from the study published by Barbanti last year in JACC Intervention, in which 300 patients underwent coronary angiography immediately before and after PCI. And in 7.7% of cases, unsuccessful cannulation was demonstrated, especially for the right cannulation, and in most of the cases the problem was the Evolut valve, but also the implantation depth and the ratio between the transcatheter up valve and the sinuses of Valsalva. And this is a problem when performing coronary angiography in elective condition, but imagine having troubles in acute coronary syndromes. We have data from different registries reporting an heterogeneous prevalence of acute coronary syndromes after TAVI ranging from 4.5% to 10%. But in general, acute coronary syndromes are associated with increased in-hospital and long-term mortality. And why? Of course, we have an advanced age population with a high comorbidity burden, and also some pathophysiological mechanisms different than atherothrombosis might be involved, like coronary embolism, light vein migration, impaired coronary flow. And also, of course, there is the problem of the interaction between the valve and the coronary ostia that might sometimes even preclude the primary PCI. So let's read together the study. So this is a multicenter international study involving 38 centers. Among a population of over 42,000 TAVI recipients, only 118 experienced STEMI follow-up. So the cumulative incidence is extremely low, 0.3%. In this population, mechanical obstruction in the index TAVI procedure were excluded. All patients underwent coronary angiography before TAVI, and pre-TAVI PCI was performed according to clinical judgment, as well as TAVI indication, valve type, valve approach were defined by local heart team for each center. And the definition of STEMI was according, of course, to the fourth universal definition of myocardial infarction, as well as the management that was performed according to clinical judgment and guidelines. Among the population of 118 patients, 102 underwent primary PCI, and this population was compared to a population of all comers, STEMI non-TAVI patients from 5 high-volume centers for a total of 439 patients. So, among 42,000, over 42,000 TAVI recipients, 118 experienced STEMI, and among these, 102 were treated with primary PCI and were compared to STEMI in non-TAVI recipients. So these are the population characteristics. So we are dealing with an aged population, 80 years old, the mean age, with significant comorbidities like diabetes, dyslipidemia, hypertension, atrial fibrillation, COPD, chronic kidney disease, and 70% of the patient had a history of previous coronary artery disease, 29% previous MI, and 13% previous CABG. We are also dealing with a population that is at, we can say, moderate to high surgical risk. The mean STS mortality risk was 5.6%. The TAVI was performed mostly by transfemoral approach, implanting balloon or self-expandable, and also 8 patients that experienced STEMI had received a valve-in-valve procedure. At discharge, most of the patients were discharged on dual antiplatelet therapy, but also there were patients on single antiplatelet and oral anticoagulation with or without antiplatelet. As I said, all patients underwent coronary angiography before the TAVI, except one that underwent coronary CT scan. And complete revascularization was described for 60% of the patient, when complete revascularization was defined when all lesions in vessel over 2 millimeters of diameter were treated. Instead, lesions in small vessels and chronic total occlusion were medically managed. So the median delay between TAVI and STEMI was 255 days, but this is very heterogeneous because we are ranging from 9 to 680 days. 35% of STEMI, anyways, occurred during the first month after the TAVI procedure. So these are the clinical characteristics. Time from symptom onset to hospital arrival was pretty short, 130 minutes. There were anterior, inferior, lateral infarction. I would like to underline the Kilip class that was 2 or more in a significant proportion of patients, and in over 20% of patients, there was a Kilip class 3 or 4. 11% of patients presented in conditions of cardiac arrest. And how was the STEMI managed? So one patient underwent pre-hospital thrombolysis, 102 underwent primary PCI, and we also have 15 patients that were assigned to non-invasive strategy. The P2Y12 inhibitor that was administered mostly was clopidogrel, and also we have data from anticoagulants administered, and 2 patients were treated with ECMO as a circulatory access device. In-hospital outcomes are extremely poor because we have a mortality, in hospital mortality of 25%, 7% of stroke, 6% of atrial fibrillation, 30% of acute kidney injury. At discharge, most of the patients received APT, but also there were patients on oral anticoagulation. We have a high prevalence of atrial fibrillation in this population. And those poor outcomes were confirmed in long-term follow-up. At 1 year, we have a 33% rate of mortality. Stroke rates are stable because all of the strokes occur during hospitalization. We also have a rate of myocardial infarction of 7.7% at 1 year and a cumulative incidence of MACE of 42% at 1 year. 15 patients, as I said, underwent, we can say, conservative treatment. So they did not undergo primary PCI for STEMI because of many reasons. There were patients that were too old, too frail, patients that were late presenters, and also patients that died before even going to the cath lab, so cardiac arrest and resuscitation failure. In the cohort of patients undergone primary PCI, this cohort was compared to non-TAVI STEMI patients. And now we can see that these patients are extremely different because we know that STEMI usually occurs in patients that are younger. And in fact, we have all the baseline characteristics of the populations that differ in terms of age and comorbidities, and also a previous history of coronary artery disease, previous MI, previous CABG. The clinical characteristics, we have differences in localization of the infarction, anterior versus inferior. And also another time, we see that there is a difference in TLIP class because 80% of patients with the STEMI non-TAVI were in TLIP class 1. Instead, a significant proportion of patients in the STEMI post-TAVI group were in TLIP class 3 or 4. These are the angiographic findings. So there were differences in the culprit lesions, and the 26% of patients had the three-vessel disease, 13% of patients had the three-vessel disease in the STEMI post-TAVI, and 16% in the non-TAVI group, so not a significant difference. We have differences in the type of drugs administered because clopidogrel was mostly administered in the TAVI population. Instead, we have half of the patients receiving ticagrelor and other potent inhibitors, but also 14% of STEMI patients, non-TAVI, received clopidogrel in 41% of cases. This is interesting. Authors described for patients with STEMI post-TAVI a mechanism other than atherothrombotic in a significant proportion of patients, and those were stent thrombosis, definite coronary embolism, possible coronary embolism, left valve migration, and stress cardiomyopathy. Going to the technical aspects, we can see the first difference. Most of a significant proportion of TAVI patients were treated through a femoral approach. Instead, most of the patients, non-STEMI, of course, they received primary PCI through the radial approach. Moreover, we have a significant proportion of patients in the TAVI group that received non-selective injection for the left and the right coronary artery in 22% of cases. All the procedural details, so procedural time, fluoroscopy time, radiation exposure, contrast volume, were increased in post-TAVI STEMI group compared to non-TAVI. And we also, these are all other technical characteristics of the two populations. I would like to focus on this aspect that is pretty significant. We have an extremely significant rate of PCI failure in the population of TAVI. 16% of PCI failure. In fact, we have a TIMI flow grade after the PCI that was 0 or 1 in 16% of cases. And the reasons for PCI failure were identified as failure to cannulate the coronary ostium, failure to cross the lesion, no reflow, coronary perforation, and procedural death. And all of these outcomes were, of course, more prevalent in the post-TAVI population compared to non-TAVI. These are the images reporting the same data that I already showed. So time from symptom onset to hospital arrival was shorter in the TAVI population, but door-to-balloon time, procedural time, fluoroscopy time, radiation exposure, and contrast volume were all higher in the TAVI population compared to non-TAVI population undergoing primary PCI for STEMI. The authors also performed a regression analysis identifying the predictors of mortality after STEMI in the subgroup of primary PCI. And actually, a glomerular filtration rate under 60, a Killip class of 2 or more, and PCI failure resulted as independent predictors of increased mortality in the primary PCI group of patients with STEMI following TAVI. So in conclusions, the incidence of STEMI after TAVI is 0.3% at a median follow-up of 255 days. Median door-to-balloon time is higher in TAVI population, as well as procedural time, fluoroscopy time, DAP, and contrast volume. We have a significant PCI failure rate, which is fourfold higher than compared to normal STEMI patients, 16.5%. And of course, we have poor outcomes, so both in hospital, high mortality rate, and low, and also at 1 year follow-up. At multivariate analysis, glomerular filtration rate inferior to 60, Killip class above 2, and PCI failure were independent predictors of increased mortality after primary PCI in STEMI group. So these outcomes are actually comparable to those already reported in literature, because STEMI is not very common after TAVI. The incidence in all the studies is under 0.5%, but I think it is a significant problem because the mortality rate is extremely high. We have seen that in this paper, we have a 20% of in-hospital mortality, and at 1 year, 31% of mortality. And this is similar to other rates of mortality and incidence reported in literature. So in order to introduce the discussion, I would like to add some slides about if there are tips and tricks for coronary engagement after TAVI, and how to potentially reduce the risk of having trouble in performing PCI after TAVI. So these are insights that I took from this app, TAVR Catide, that was developed from Mount Sinai, which gives, I think, some interesting tips and tricks on coronary engagement after TAVI, and also some webinars. I'm a young operator. I don't have so much experience in performing PCI after TAVI, of course, so I would like to also hear the opinion of the expert discussants. But you have to know your type of your valve type. So if it's a self-expandable, a balloon expandable, a supraannular or an infraannular. So sometimes the transfemoral approach should be preferred. Sometimes it's useful to perform orthography before PCI, especially if the patient already failed a coronary angiography or another PCI. For the left coronary angiography, left coronary artery cannulation, some colleagues suggest to use an half-size smaller guiding catheter, or for the right coronary artery to use a different catheter other than Jenkins right, like the Amplatz left 0.75 of the multipurpose. And of course, you sometimes have to deal with the non-selective wiring of the coronary ossia using guide catheter extension and balloon anchoring. Of course, all of these techniques are much safer in stable conditions that compared to acute coronary syndromes and STEMI. So how could we prevent this problem? Performing complete revascularization before TAVI is not so demonstrated to be useful, because 1/4 of patients undergo complete revascularization before TAVI, but there is not a significant level of recommendation because there is no evidence that this might impact on mortality. In fact, the data presented last year from the activation trial show that there is no benefit in performing PCI in all patients before TAVI. And also there are reports that performing a combined PCI and TAVI procedure might increase the procedural complexity, procedural time, radiation exposure, contrast load, and also might be associated with increase in hospital vascular complication and mortality. So probably we should prevent the problem. And one potential thing is the Commisure alignment, because if you have the commissures of the leaflet in front of your coronary ossia, so you are misaligned, and maybe it can be impossible to selectively engage coronary artery. So there is increasing evidence about the possibility to align the commissures, also with TAVI, because surgeons always align the commissure when perform surgical valve replacement. And this is true for the SAPIEN, the Evolut, the Accurate, also the Portico valve. And of course, you have to know how your valve is made, how if there are, we can say, some markers, some radiopaque markers that can help you to orientate the valve. For example, for the core valve, you have the C-tab that correspond to your commissural pod, so you can align the commissure with the core valve, but also with the Accurate, the Boston valve. If you know how the valve is made, you know that there is a freestand strut in corresponds to the post where the commissures are located. So if you see the image of the crimped valve, you can orientate the valve, especially if you use the cusp overlap view, in which you have on one side the overlap of the right and left coronary cusp, and on the other side the non-coronary cusp. And these are images taken from colleagues from San Donato. They orientate the delivery system in order to achieve commissure alignment after a study of the basal CT scan. So it is possible to achieve commissure alignment potentially. And my question for the discussion are this one. So we have seen that STEMI patients have an extremely high mortality rate, but how much of that is linked to the impossibility to perform a good PCI? Because we are also dealing with a significantly aged population with several comorbidities. So I think there is a combination of both elements. Should we raise more concern about the problem of coronary access? And the future need for coronary access should influence the device selection or implantation technique. And this is for the TAVI operators. Is commissure alignment the new goal? And did you find any increased procedural complexity, or is it something easy to achieve? So thank you for your attention. I finished.
Okay, thank you very much, Evelina. That was a very nice overview of a complex topic. I think you picked up lots of different strands there that we can discuss about higher mortality, coronary access, and how we can improve things for the future. Can I invite Carlo Tumscitz, if you're available with us, if you can perhaps give your comments on this field and this topic, and especially your experiences for a lot of us young fellows.
Thank you very much, Evelina, for your truly brilliant presentation. The study is truly very interesting. I think there are much data to discuss. Actually, I think there are many different aspects that we could highlight about STEMI in patients treated with TAVI. I think the first one is that this is an emerging problem, because probably in the next years, if you are dealing with the younger patients, the number will increase dramatically. So if the problem now is just seen for a few cases that anyone who has an experience faced struggling and trying to re-engage the coronary artery during a STEMI, I think in the future it will be a true problem. For example, how can we deal with this risk if a patient has the possibility to do TAVRs or surgical aortic valve replacement instead of TAVI, when in the succeeding 10 or 20 years they could face a STEMI, and then the prognosis could be dramatically different. So I think it's a topic we have to discuss and to evolve really in the next years to understand which will be the limit of implanting TAVI in younger patients. Despite that, I think there are things that can be solved. For example, I think techniques that derive from CTO or complex procedures should be something like familiarity. Anyone should be able to use these complex techniques in normal PCR, or at least know how to perform this procedure with guiding extension and trapping technique. Because I think this is one of the main tricks that should be used in this patient to overcome the problems that you could face STEMI. But of course, this is not enough. And I think Commisure Alignment is not the true answer of this problem, because I think there is much more to study about this. We discussed a lot with Arif about this problem, because I think there are many things that could be done. Obviously, new valves could help the patient, but I think one of the first things that should be assessed is for patients who are going to have TAVI, you should try to understand if the patient could encounter this problem in the future. And if there is a high risk of difficult coronary cannulation, I think one simple thing that you could do is that after TAVI implantation, you should try to understand cannulating the coronary, if there is a way to do it before the STEMI exists. Obviously, there is no card or anything that the patient could bring, and if has a STEMI, they just give the card, okay, you have to use this catheter. But of course, this is a study that every physician should do in each patient to understand that there is a problem, additional problem or not, because normally this is not an issue. It's an issue when there are some characteristics of the coronary ostia and the position of the valve that makes the cannulation very difficult. For example, if you need to do a double angle, like going in different direction after crossing the valve strut, this means that with the normal catheters, with standard catheters, cannulation and PCI is very difficult. This is just some of the things that comes in mind, but obviously discussion can be made on several topics.
Okay, thank you very much, Carlo. Some very useful, I think, tips and tricks there. Francesco, are you on with us?
Yeah, I'm here, Arif. So good morning, everybody. Many thanks to Evelina for a very interesting presentation. So first of all, I want to just to add a couple of comments of what Carlo already said. We know today that the rate, the incidence of ST elevation after TAVR is 0.3%, but we have to consider that some of these patients die during the first year. So among survivor patients, the rate of ST elevation myocardial infarction is higher, and it will become much higher with the TAVR in low-risk population. So the first question, implanting a stent, we know that does not prevent acute coronary syndrome, so should not the answer. What we have to do is just what we do in our clinical practice. What I do in very old patients that are the majority of patients that today undergo TAVR, I just treat, if the coronary disease is stable, the proximal vessels. I try to avoid to treat distal vessel, because in this patient, the main problem is the severe aortic stenosis and not the coronary artery disease. So I want to do my TAVR without problem. So if I have a proximal LAD stenosis, I perform a PCI, otherwise I do not, if the patient is not symptomatic for angina. Most of the ST elevation myocardial infarction were observed within the first months. This is probably again because we have today 20-25% of the patients that die during the first year. So this is probably a bias of the study, a bias of related to the fact that we lose most of the patients after the first year and after the first months. We have different mechanisms of ST elevation MI, because we have two different populations as compared to the common ST elevation MI. So probably we have to accept that there are different reasons for which this patient develop a myocardial infarction, and of course are more complex patients, the mortality is higher because of that. Some practical aspect, I would say that we have always to think about potential coronary re-engagement before performing the TAVR, and we have to try to give to the patient the best. We still don't know if alignment has an impact as a clinical impact. We know that potentially can help in coronary engagement, but it is not still demonstrated in true patients. But it's something that at least theoretically works, and we have to also add disadvantage to our patients. Even if the procedure is a bit complex. Of course, when we do something new, is at the beginning much more complex, but after performing the first cases with taking care of the alignment, the procedures became faster. I think it's something that we have to start doing in our daily practice, and after the first cases, it will become easier. We have to think especially about device selection and implantation aids. So in patients at a very high risk of acute coronary syndrome after TAVR, I mean patients with multiple risk factors, we have always to think about low profile valve, and sometimes we have also intentionally tried to promote their engagement by implanting the valve a bit lower. Maybe we will pay something in terms of per maker implantation, but we can at least facilitate a potential re-engagement. And I would say that probably this is a problem in native anatomy, but it is a very big problem in valve, and there are not so many papers published in this topic about re-engagement after valve, but we know from our experience that here is a very big problem. So we have to try to optimize as much as we can in this procedure our results. And I would say some practical aspect when we have to manage a patient with acute coronary syndrome after TAVR, I would suggest always to start with the femoral access to save some time. If something does not work, we have to change our strategies because we still don't know how we engage coronary ostia in this patient. What we do is what we do in standard patients at the beginning, but if it does not work, we have to change our mind. We have to try alternative strategies, even with the new catheters that we don't routinely use in our clinical practice. Sometimes I notice, Evelina said we have experience, but this is not true. Even if probably there is not somebody that did more than 10 cases of PCI after TAVR. So we try to think and try to give the best to our patient, following what we learn from some anecdotal cases. So sometimes I notice that we can engage coronary ostia just going with our catheter around the frame of the valve. So this is why if the EBU of the Judkins for the left coronary artery does not work, I try soon with the Ampla cell 1, trying to sit the catheter in the opposite cusp and try to reach eventually by using eventually by wiring the coronary, even if I'm not selective, and then by using a guide extension. This is what I can say. I learned from 3-4 cases that I have done until now. I saw some cases in which it was not possible and there was nothing to do. And this is especially true for the right coronary artery, and especially when it was utilized a very high profile valve like the core valve or the portico. Even if the portico, if we have to use a self-expandable valve, may help because of the large cell of the frame. Thanks, Evelina.
Thank you very much, Francesco. So I think now,
Sorry, can I add
anybody
just one brief
has any
comment?
questions, we probably have a couple of minutes left before wrapping things up. So if there's any questions from the audience about the paper, for Evelina or about the field. Yes, go
if
ahead.
I can add a very, very fast comment, because I think we don't have enough data to say that we don't have to do PCI in patients before TAVI. I know there are studies that are negative, but I think we should mention that in FAME trial, FAME 2 and FAME 3, we had some clue that there are a reduction in myocardial infarction in patients with functional positive lesions treated. So I think this could be the way to go in patients with several disease, in several multivessel disease in the coronaries. So trying to do functional complete revascularization in this patient may reduce the additional PCI in the vessel. That's the only thing we know, because I think that the data is not too rich to be so strictly about leaving the coronary as it is. Mostly because of this problem that could be encountered later.
Okay, thank you. Yeah. So anybody have any questions about, again, this paper or this field for our experts that they want, or some advice anybody wants?
Arif, sorry, I just would like to ask a question to Francesco. Because sometimes it happens that when you are dealing with coronary reaccess, especially with core valve, which has a very tight stent frame, after you do PCI, if you are selective cannulated, your catheter can get stuck. How do you pull your catheter out without having troubles with the valve? Do you have any tips and tricks to do that?
Yeah, if we reached the coronary ostium just through the frame of the valve, probably we should be able to pull the catheter back. So it never happened to me. So what I can say, you have just to pull the catheter harder, but honestly, I don't know. If you were able to go through the frame of the valve, probably you have to be able to come back with your catheter through the same frame. What I had a case in which it was a valve in valve. We just protected by wiring and parking the stent in the right coronary artery. At the end, we decided not to implant the stent, and pulling back the stent, it came stuck into the valve frame. At the end, we had to place the stent. Half of the stent was into the heart, half of the stent in the coronary, but it was not possible to come back the stent, and we had to implant it. Finally, the procedure was fine, but to me, never happened to observe the same with the catheter. I don't know how answer to your question.
Okay.
I could say just
so I think does anybody we'll take one last question and then we'll...
Arif, I have just a curiosity. We
Sorry,
saw
Carlo,
that...
go on, come in.
Oh, sorry, yeah. Carlo, do you want to add something, Carlo?
No, just one brief comment about the fact that in case of trapping, I think the most important thing is to understand why the catheter has been trapped. So if there is a kinking or whatever. So before pulling back, you should be able to understand the mechanism. So carefully use the multiplanar view to understand what's the problem, and probably trying to avoid, if it is a kinking, avoid kinking with the stiff wire inside of the guiding cap. I think it will be easier to retrieve it, but it depends from the mechanism. So it could be a very bad situation if you have a bad kinking in that situation.
One quick question. We saw that a mechanism of STEMI in TAVR patient could be embolism. So if we think about embolism, the prevalence of atrial fibrillation in such patient and the possible problem of valve thrombosis. Do you think that antithrombotic therapy or anticoagulant therapy approach in this patient could help us preventing, I don't know, or better treat our patient?
So, Francesco?
Sorry, I got the call, so I missed part of the question, but sorry, can you repeat, Julia?
Yes. We saw that embolism is a possible mechanism of STEMI in TAVR patients. So we're thinking about embolism, the possible problem of valve thrombosis, and the prevalence of atrial fibrillation in this patient. Do you think that a tailored antithrombotic or anticoagulant therapy approach in this patient could help us?
Absolutely. This is something that we sometimes observe. Is the same concept of periprocedural stroke because of atrial fibrillation, periprocedural atrial fibrillation. Yeah, I think here probably the only tool we have is the antithrombotic treatment, and we have to try to give the best to our patients. And we have always to think about the potential cause of coronary embolization related to atrial fibrillation or related to thrombus that we can have in the valves. Yes.
Thank you.
Julia, if I can add one thing, is that you should be the patient should be assessed in the first month to see if there is an increased gradient over the new valve, because I think it's not so uncommon to see some components of valve thrombosis. So I think in these cases, using anticoagulants may reduce also the embolic event in these patients, obviously.
Yeah, I believe so.
Okay, great. So we're just on time now. So finally, I'd just like to say big thank you to Evelina. I think you took on a challenging topic and a difficult paper, but really nicely done. Very great. Thank you very much, Carlo and Francesco, for joining the discussions and sharing a lot of your personal experiences and insights. And I think if we want to take some take-home messages for everybody today, probably what we've learned from all the discussion to summarize is, when thinking particularly about coronary access, it's important the valve design that you put, so the type of valve you choose. It's important how you implant it, thinking about implantation depth and commissural alignment. And even then, if it's challenging, we need to think and be creative, probably, with our cannulation techniques and catheters that we use. And the step to the future is now we have to think about this problem, not just after TAVI, but after TAVI and TAVI, valve and valve TAVI, and eventually probably TAVI and TAVI and TAVI. So good luck for all of us in the future cannulating these patients. I don't think it'll be the easiest of thing that we have to deal with. So thank you very much, everybody. Thank you again, Evelina, and all our senior experts. And have a nice weekend, and see you again next week.